Thanks for the introduction. These are my disclosure. And metabolic associated steatotic liver disease, known as MASLD, is nowadays, unfortunately, the most common liver disease worldwide. And in the last 10 years, there has been a very rapid increase of the prevalence of the disease. Even though the majority of patients have benign steatosis, the disease may progress to MASH, steatohepatitis, and to cirrhosis with its complications. And MASLD is the most common liver disease. However, the majority of patients that are affected by the disease are not aware of it. Only less than 5% know that they have this liver disease, even though the disease is already at a late stage. So it's very important to diagnose the disease at an early stage. And a study in a very large population has shown that even patients with simple steatosis, they have a higher risk of mortality and complications respect to patients without liver steatosis. And there's a fibrosis progression not only in patients with MASH, but also in those with simple steatosis. And this, we know that diet and lifestyle change may modify the natural history of MASLD. Therefore, it's very important to diagnose the disease at an early stage. And this could be done using quantitative assessment of liver fat content. There are 3 parameters available: the attenuation coefficient, the backscatter coefficient, and the speed of sound. On the Canon system, we have the attenuation imaging, and it's a real-time color mapping in a large sample box. Vessels and ligaments are filtered out from the calculation of the attenuation coefficient, and the attenuation is also color-coded, so it's possible to visualize artifacts and to exclude them when the measurement is made. There's also the possibility to assess the quality of the acquisition using the R-square value, and a very good acquisition is equal to or higher to 0.90. There are several studies that have been published using either histology or PDFF as the reference standard. And it has been shown that there is a high accuracy in detecting liver steatosis, but also in grading liver steatosis. And it seems that advanced stage of liver fibrosis or inflammation are not associated with the attenuation coefficient. There are confounding factors that we should take into account. And these factors are mostly the depth of the measurement box and the size of the measurement box. The scan location may affect the values and the reproducibility, and as for the free breathing, the reproducibility may be affected, whereas the breathing phase or eating, drinking, or liver fibrosis, they do not affect the value. The most important issue is the death dependence. It has been shown in a study conducted together with Professor Barr that it is in this confounding factor is present not related to a specific algorithm. This study was performed using 3 different algorithms from 3 different vendors, and we observed a decrease of value, increasing the death. This means that a standardized protocol should be followed to obtain consistent measurements. Otherwise, there's a variability between operators, but a variability also has been observed between studies that were published before suggesting the protocol. This is the one suggested in the latest guidance for liver fat quantification released by WFUMB. Fasting is not mandatory, but patients should be fasting in a multiparametric assessment of the patients because the liver stiffness acquisition protocol should be prioritized. Breath hold and the best quality of the bimode image, but not necessarily with a transducer perpendicular to the liver capsule, as we do for the assessment of liver stiffness, intercostal space, the measurement box perpendicular to the transducer. The length of the measurement box should be a fixed one and is 3 centimeters, and the upper edge of the measurement box at 2 centimeters below the liver capsule. This is important for the death dependence. To assess the variability between consecutive measurement, IQR over median is suggested, even though it is not so important as for liver stiffness assessment. We suggest median or mean value of 3 to 5 acquisition, and when there is a manufacturer quality criterion, it should be followed. And in the case of ATI on the Canon system, there is now the possibility for the user to adjust the sample box respect to the liver capsule at 2 centimeters using a guide that appears as an horizontal line on the image on your screen. And this horizontal line that is above the vertical line. Median or mean value is the same. If we use the mean instead of the median, the accuracy is the same. But also 3 or 5 acquisition. When we perform the liver fat assessment with the system is quite easy, one measurement after another, once a very good ultrasound image is obtained. So it's a very rapid acquisition. There is a variability between attenuation coefficient obtained with different systems. And in this study, we used 8 algorithms from 8 different vendors. You see the green box and the blue box. Green box, subjects without liver steatosis. Instead, the blue box, presence of liver steatosis, PDFF was the reference standard. These algorithms were able to assess the quantity and to grade the liver steatosis. However, all the values were up and down. There was not any agreement between vendors. So it's very important to have currently cutoffs that are system-specific. And for the ATI on the Canon systems, these are cutoffs obtained not in a single study, but in a meta-analysis analyzing individual patient data. So these results are robust. 11 studies, almost 1,400 patients. PDFF for biopsy was the reference standard, and there was also validation cohorts. And these are the cutoffs that I suggest you use for detecting and grading liver steatosis using the ATI algorithm. And it was confirmed that liver fibrosis is not affecting the value of the ATI in the patients that had the liver biopsy as the reference standard. And what is worth noting is that a better performance of the ATI was observed in this meta-analysis. Then it was significantly better with fewer misclassified cases. It was reported already in other studies, but these results were confirmed in the meta-analysis. We have the possibility with the Canon system to perform also and to obtain also other parameters, and this is very important in patients with the chronic liver disease, to have a multiparametric approach, BMOD, Doppler, SUS, and so on. I'm focusing now on shear wave elastography and shear wave dispersion. And this algorithm has the possibility also to have a propagation map to assess the reliability of the measurement and the quality of the measurements that is obtained. And it can visually be assessed by the operator. What are the cutoffs? The rule of 4 has been proposed for using the ARFI-based techniques independently on the vendor. And the rule of 4 can identify patients with a compensated advanced chronic liver disease. These are the patients that most need to be followed up for complications. And at a cutoff of 13 kPa, the advanced liver disease is ruled in, and 21 kPa, there's a high probability of a clinically significant portal hypertension. It's not suggested to use a histologic scoring system, because using shear wave elastography, we have a continuous increase of numerical value, not a scale like in histology. But another parameter is dispersion. It's a very intriguing parameter. Dispersion is related to the frequency dependence of the shear wave speed, and is affected by the attenuation of the shear waves, and is due to the viscous component of the tissue. It's a parameter that is acquired together with the liver stiffness, and combined in a score, it has shown a good performance for detecting inflammation in patients with MASLD. However, factors that may influence the dispersion results are not yet well understood, and there are few studies, but also conflicting results in the literature. I'm reporting the results of the iLEAD study because it's an international multi-center study. Liver biopsy as the reference, all patients with MASLD, and 3 parameters were obtained: the shear wave speed, the attenuation coefficient, and the dispersion. And there was a very high high accuracy for shear wave speed, for elastography, for the attenuation coefficient. For shear wave dispersion, the performance for grading inflammation was suboptimal. I should, however, underline that in this series there were few cases with severe inflammation. It's not recommended yet to use the value in clinical practice, but in research studies it's very important to use it to understand, to have evidence about the value of the shear wave dispersion. So in conclusion, the ultrasound systems are widely used for screening liver disease. They may allow a thorough evaluation of the liver, and we have several parameters, as I shown before, and they can be used to assess not only for diagnostic chronic liver disease, but also to follow up the patients over time. And the multiparametric approach helps in evaluating the efficacy of the treatment or the progression of disease. For to have more details about the shear wave elastography and the multiparametric approach, also with the fat quantification, the World Federation guidelines guidance were published last year, and they are freely available because were released as an open access. Thank you for the attention.